Diagnose what is the normal X-ray. Okay, normally placed X-ray, not a normal X-ray, because the technician can change your diagnosis. If the X-ray is not properly placed, there will be various diagnoses with the same patient. Okay, so before that, you have to know whether it is a properly aligned, properly placed X-ray. So there are certain criteria, and one thing is important in our clinical practice. Shoulder AP views is only the important view, no lateral view. All other structure, AP and lateral is the important structures. Knee AP lateral, spine, cervical spine AP lateral, ankle AP oblique, sorry, AP lateral. Okay, so in case of a shoulder AP is enough in our clinical practice. So you write down shoulder AP view, enough. Okay, never write down shoulder lateral, shoulder axial. It is not needed in our clinical practice. So okay, so this is a normal X-ray. So normally placed X-ray. You can see this is the AC joint subluxation. There is a AC joint injury here, and all except this, the shoulder is normal. Okay, and we can see this is the glenoid, this is the clavicle, and this is the acromion AC joint, acromion, and this is the coracoid process. This is the glenoid, this is the glenoid labrum, this is the glenoid cavity, and it is the humeral head. And we can see there is a glenoid, and you can see the humeral head. There is a gleno-humeral relation. This is very important. Doctor, കാണുന്നുണ്ടല്ലോ അല്ലേ?
Yes, sir.
Okay, this is the most important criteria for diagnosing a shoulder pathology, whether it is a normal or an abnormal. So it is the glenohumeral. There is a glenoid cavity. You can see the anterior border of the glenoid, and this overlapping, it is the posterior glenoid. Okay, and it is the humeral head, and there is a clear glenohumeral relation. So while seeing a shoulder MRI, you look into the glenohumeral relation only. The very important thing is you should have a clear glenohumeral relation. So it is a normal X-ray. And second one is the lower border of the clavicle. It is the lower border of the clavicle, and is the lower border of the acromion. It should be in the same line. Lower border of the clavicle and the lower border of the acromion should be in the same line. This is the first criteria. And another one is there will be glenoid and humeral. There will be a clear glenohumeral relation. Okay, and it is a normal X-ray. Okay, you can see another. I will show you one. Okay, you see this X-ray. You can see this is the humerus. This is the head of the humerus. Okay, you can see the head of the humerus, and this is the posterior glenoid, and it is the anterior glenoid. And you can see it is slipped downward, subluxated from the normal alignment. Okay, so it is an abnormal X-ray. So the humeral head should be placed in the glenoid cavity. It is in proper alignment, and this is the subacromion space. If it is subluxated, the area is normally there will be a 14 mm. Subacromion space is normally 14 mm, and 7 mm is the average. Okay, and it is a normal X-ray. Can see it is a normal X-ray because there will be no space. Actually, there should be a 7 mm gap, but you never look on this area. You look into this area, that is the glenoid area. This is the glenoid, anterior glenoid, and this is the posterior glenoid, and the humerus head is clearly inserted into the glenoid. Humeral head is clearly located in the glenoid. There will be a clear glenohumeral relation. So it is a normal X-ray. It is the lower border and is the lower border. Okay, so it is a normal X-ray. And quack practitioners and some other doctors is not having definite knowledge about the shoulder X-ray. His shoulder is migrated upward because there are several queries from the doctors personally to my WhatsApp, and doctor, there is any subluxation, any dislocation. So it is a normal X-ray. Okay, it is a glenoid, it is a humerus. You look into the glenohumeral relation only. All others are normal, because if the patient is, if the shoulder is placed straight, or if the X-ray come from the top, it will be like this. If it is from the straight, you will get a definite 7 shoulder subacromial space. So it depends on the technician. It depends on the experience of the technician. So you look into the glenohumeral relation only. I will show you. Okay, this is a normal X-ray. You can see there is no normal. So this is an overlap, but it is normal. There will be no overlap, but it is also normal because you can see this is the glenoid, and there will be a clear glenohumeral relation. It's a normal X-ray. Okay, normal shoulder joint, no superiorly migrated, but we can see another condition, that is the superior migration of the shoulder. It is the most important pathology you can see in a sports injury or a fall. Okay, we can see this is the anterior glenoid line, anterior glenoid border, and we can see it is the posterior glenoid border, and compared to the glenoid, the humeral head is migrated upward. So this is an abnormal X-ray, but you can see there will be a space, remaining space. There will be no overlap, even though the normal X-ray having some overlap. Okay, but the X-ray was normal, but there is no overlap, but there is no glenohumeral relation. The humeral head is migrated upward, so it is an abnormal X-ray. So for differentiating normal and abnormal, look into the glenohumeral relation. So it is a condition that is called the superior migration of the shoulder, because you can see it is the spine of the capula. So the supraspinatus come in this area. Okay, so supraspinatus come in this area, and it attaches to the greater tuberosity. This is the greater tuberosity. There will be a space. This is the 7 space. So the supraspinatus come in this area and attaches to the greater tuberosity. Okay, if it is superiorly migrated, there will be a normal 7 gap. If the humerus is superiorly migrated, the subacromial space is reduced, and there will be a compression or tear of the supraspinatus muscle. So if a patient present with the X-ray of superior migration of the shoulder, there will be two possibilities. One is shoulder impingement, and another one is a shoulder rotator cuff tear. So if a patient came to OPD with this X-ray, directly you refer the patient to an MRI. Without MRI, never treat the patient. Okay, superior migration of the shoulder, there will be two diagnoses. One is a shoulder impingement, and second one is the rotator cuff tear. Shoulder impingement means the rotator cuff is crushed between acromioclavicular arch. This is acromioclavicular arch and humeral head. So that may be a supraspinatus partial tear or maybe a complete tear. Okay, so if a patient came to OPD with the superior migration of the shoulder, there will be a chronic rotator cuff tear or a massive rotator cuff tear, or maybe a shoulder impingement, so that you have to diagnose with an MRI. Okay, and with a shoulder AP, we can see this is the glenoid, and this is the lesser tuberosity, it is the greater tuberosity, this is the acromion, this is the clavicle, this is the normal shoulder anatomy, and there will be the view is more very, very important. This is the way we can get a shoulder X-ray. Okay, if it is the same level of the shoulder, if the ray passing from the same level of the shoulder, you will get X-ray like this. You will get a clear subacromial space, 7 subacromial space. If it is raised from the top of the shoulder or somewhat above from the normal line, you will get an X-ray with the acromioclavicular overlap. So there will be glenoid cavity here, and you can see there is the exact relation. Glenoid is there and humerus is the same level. You can see this is the glenoid cavity and humerus. There will be externally rotated and internally rotated X-ray. So it is in our practice it is enough. Okay, so you note this position. This is the way we will get a shoulder X-ray in normal position. If it is in the same level, you will get like this. If the technician is not that much experienced, maybe you will get an overlapped X-ray. Okay. And another one is the Y view or lateral view. Y view or lateral view. You see the X-ray, it is clinically not at all relevant for our clinical practice. Okay. And it is a shoulder axial view. A shoulder axial view is the axial. Axial view means you can see the abducted shoulder and the X-ray passes from the downward position. Just know the position. Okay. This is the axial view. and axillary view. It assesses the anteroposterior relationship and the scapular view for the posterior dislocation. But in our practice, the AP shoulder is enough for diagnosing a posterior dislocation and anterior dislocation. So I will show the X-ray later. Okay, in common pathologies in detail. Okay, and there are acute shoulder pain. If a patient came to OPD, in our practice, there are several cases directly came to our OPD after a trauma or a fall or a sports injury. So for the management of acute shoulder pain is very important, because there will be there should be an exact diagnosis, exact management, and pain should be reduced within 1 to 2 days. Otherwise, the patient will not come for the next visit. Okay, so for the proper diagnosis of acute shoulder pain, the first one is acute calcific tendonitis. So before that, there are certain fractures like clavicle fracture, neck of the humerus, shaft of the humerus, AC joint fracture, and so sternoclavicular joint injury. These are the common fracture related to shoulder, and we are not going in detail to the fracture because time is less. Okay, so another one is the rotator cuff tear and the shoulder dislocation. Okay, and if a the patient came to your OPD with a severe pain, tenderness, and she unable to move the shoulder, that much pain, that is also called kidney stone of the shoulder. Kidney stone of the shoulder, that is the acute calcific tendonitis. So we can see there will be rotator cuff muscle. So this is supraspinatus. This is the scapula. So the supraspinatus muscle comes in this area and attaches to the greater tuberosity. So there will be calcific tendonitis, inflammation of the supraspinatus muscle, and there will be calcium deposit over the supraspinatus tendon, usually seen in the supraspinatus tendon. So it is the acute calcific tendonitis. We can see if a patient came to OPD with severe pain, swelling with no range of movement, that much pain, that is also called the kidney stone of the shoulder. You directly go for an X-ray shoulder, you can see calcific tendonitis, that is tendon calcification with a severe pain, and it is the typical presentation of an acute calcific tendonitis. In such cases, immobilize the patient with a bandage, and otherwise you can take out this calcific tendon. Sorry, this is a calcified material you can take down with fine needle. Okay, but this is severely painful even after the injection or a painkiller. This is severely painful, and we have to immobilize with a shoulder immobilizer. Okay, this is the patient came to OPD with severe pain, unknowingly taken photo, and we can see this is the patient with the calcified tendon, and we can use a syringe, and we can see this is the material. Okay, if you have enough confidence and if you have definitely know the proper anatomy, you can take down the calcified material with a needle. Okay, if you are not confident, never do, because it will create another rotator cuff injury. If it is removed, there will be sudden relief of the pain. Otherwise, it will be a clear headache, because the pain never reduced even after 3 to 5 days of the treatment. So immobilize the first and give maximum Pittahara treatment like Purnavadi Kashaya. It is very important in acute shoulder pain. Purnavadi Kashaya is found to be more effective in the acute shoulder pain. Okay, Purnavadi Kashaya and Chandraprabha and Kaisharugulu. It is the apt option. And we can have tender coconut juice plus Betumaran 2BD for sudden relief of the pain in such acute calcific tendonitis. So it is actually in our practice is not manageable. Okay, that much severe pain, and this area is actually it is a vast area, clavicle fracture in case of a green stick fracture. In case a young child, a sling is enough, not a need of immobilization. Okay, you have to write down in case of a children, both shoulder AP. Okay, this you can see the clavicle fracture. Okay, so compare with the opposite side, you can have a sling is enough. Okay, and in case of definite fracture of the clavicle, you can have that shoulder bandage or a clavicle brace. It is the clavicle brace. Okay, if it is a displaced fracture, these both are came to my OPD. Okay, there will be more chance of complication. I refer the case for surgery, and it is manageable because there is a more chance of it's an open injury. Okay, and we can have a shoulder bandage for any acute shoulder pain. You can have a shoulder bandage for 2 to 3 weeks. The duration of immobilization of any shoulder injury is 2 to 3 weeks immobilization. Okay, and if it is a rotator cuff or a massive tear, you can have a shoulder immobilizer also. So the maximum duration of a shoulder bandage is 2 to 3 weeks. If it is a fracture, you can immobilize for 1 month. Okay, and we can see in case of the displaced fracture, this is a displaced fracture of the shoulder. You can see a displaced fracture, and you can use a simple shoulder immobilizer or a clavicle brace. And we can see the same patient came to my OPD again after 8 months with another shoulder pain. You can see a bridging callus formation. Okay, the same patient developed a clear callus. So there is a radiologically united X-ray. Radiologically, it will take almost 6 to 8 months for getting a complete callus. Okay, it is the bridging callus formation. So even after displaced fracture without a touch, okay, you can have a simple clavicle brace for 1 month. So for a clavicle fracture, the duration of immobilization is 1 month with a clavicle brace or a shoulder immobilizer. Okay, in case of a soft tissue injury like rotator cuff injury, labral tear, etc., the maximum duration of immobilization is 3 weeks. Okay, and this is the clavicle brace. And so coming to our diagnosis, and the first one is the AC joint pathology. You can see the rotator cuff, sorry, the area I'm touching is the top of the shoulder. So on the top of the shoulder, and it may radiate towards the clavicle. The pain may radiate towards the mid and medial clavicle. In some cases, there will be a painful lump. In some cases, there will be normal appearance. There will be only tenderness. There will be no lump over the top of the shoulder, but there may be a tenderness. In some cases, there may be a painful lump. Okay, so in both cases, you can diagnose as a AC joint pathology, pain over the top of the shoulder. And it can be diagnosed if the patient is having pain on abduction above 90, that is above 120 degree. Okay, it is the 90 degree abduction. It is the 120. If the patient developed more pain after 120 degree abduction, you can diagnose it as a AC joint pathology. Okay, so first diagnosis is pain on the top of the pain and tenderness on the top of the shoulder. There may be a painful lump or not. Okay, maybe a painful lump or not. There will be painful pain and tenderness over the top of the shoulder is the first one, and second one is the crossover chest adduction. As the name indicated, crossover chest adduction. Okay, from the side like this. Okay, from the level of the chest, crossover chest adduction. Touch the opposite shoulder like a Dugas test. Okay, at the level of the shoulder. So the crossover chest adduction, you develop a pain on the top of the shoulder. So it is the AC joint pathology. So there are the three criteria. One is there may be or may not be a painful lump. There may be a tenderness over the top of the shoulder, and the pain will be aggravated after abduction over 120 degree. Okay, abduction over 120 degree, the pain may aggravate, and there will be crossover chest adduction test. Okay, crossover chest adduction test will be positive in case of a shoulder acromioclavicular joint pathology. So X-ray, you can take X-ray shoulder AP. Okay, X-ray shoulder AP is enough, but the AC joint pathology, the possibility of there were differential diagnosis of AC joint pathology is in case of a patient with heavy weightlifting, like porters and weightlifting job. Patient is having weightlifting job, they may develop weightlifter's osteolysis. Okay, if a patient without a definite history of trauma, if a patient presented with AC joint pain, if a patient is having definite history of heavy weightlifting, it's a daily job or any other activities, the most probably there will be a weightlifter's osteolysis. If a patient develop AC joint pain without a trauma, the mostly the diagnosis will be weightlifter's osteolysis. You have to ask the patient about his job. Okay, there will be weightlifter's osteolysis. The patient may present AC joint pathology. Okay, and in other conditions, if the patient having a history of weight fall over the shoulder, patient with the history of fall or a weight fall over the shoulder, or a patient fall with the elbow flex. In both cases, the patient may develop AC joint pathology. So write down an X-ray, shoulder AP, and you can diagnose a TB shoulder, you can diagnose a OA shoulder and the subluxation. Okay, this is the AC joint dislocation came to my OPD after an acute fall. We can see a painful lump. We can see a painful lump over the AC joint. Okay, and this is the X-ray of the acromioclavicular joint. We can see this is the complete, that is the dislocation of the AC joint. Okay, in such cases, there will be a joint strapping method. I will show you the video if the time permits. Okay, how to do AC joint strapping. Okay, so this is the AC joint pathology. And the management of the AC joint pathology is, if the patient is having a history, definite history of trauma within 1 week, if the patient, you get the patient within 1 week after the trauma, you go for bandage with immobilization. Maybe Murivanna, it may be a Nagaradi. If it is severe pain and swelling, Nagaradi with Jadamyadi, and immobilize the patient for 2 to 3 weeks. Okay, if it is an AC joint dislocation or pathology, dislocation or a subluxation, go for a joint strapping method. Never go for a simple bandage. Okay, and if a patient came to OPD without history of trauma, but a chronic OA changes, chronic shoulder OA or AC joint OA or AC joint inflammatory arthritis, never immobilize a patient. This is very, very important. So, proper history taken. If there is no history of trauma, never immobilize a patient with the AC joint pathology. Never immobilize a patient with the AC joint pathology if there is no definite trauma. If there is a definite trauma and you get the patient within 1 week, you go for a bandaging, you go for immobilization. With the history of trauma, if you get the patient after 2 to 3 weeks, you can have labana, you can have bandage, but never immobilize. You can have a bandage, but never immobilize the shoulder. Okay, this is very important. And in case of AC joint separation, mostly there will be coracoclavicular ligament rupture and acromioclavicular ligament rupture. Okay. So in such cases, joint strapping is the ideal method. You go through the area. Okay. So we can see this is the lower border of the acromion and this is the clavicle. So there will be a subluxation and there will be a gap. Acromioclavicular widening. Acromioclavicular widening. If the patient presented with acromioclavicular widening, this is the acromion, this is the clavicle, this is the widening. So if a patient presented with acromioclavicular widening with the history of trauma, it may be dislocation or the subluxation of the AC joint. If a patient with acromioclavicular widening without a history of trauma, mostly it may be a AC joint osteoarthritis or it may be a AC joint tubercular arthritis. TB of the AC joint is very, very important. AC joint pain, swelling without a history of trauma, it may be a AC joint arthritis or TB of the AC joint. It is very, very, very important. Never miss the diagnosis. With a clear history of trauma, it may be a dislocation of subluxation. It's not a matter. But without a history of trauma, if the patient develop pain, swelling over the AC joint, it may be osteoarthritis of the AC joint, or it may be a tuberculosis of the AC joint. You have to rule out with the CBCSR and CRP or an MRI. If the MRI suggests of the TB, you go for a CB-NAT test for by collecting the fluid from the AC joint. Cartridge-based nucleic acid amplification test. CB-NAT, it is available in District Hospital and TB Hospital to rule out the AC joint tuberculosis. Okay. AC joint subluxation or dislocation. This is the AC joint fracture. Okay. So this is the joint strapping. The patient after the joint strapping, and I will show the videos how to manage AC joint strapping. If there will be a wound, okay, the patient place a cotton pad. Mostly, if the patient having history of weight fall over the shoulder, maybe a AC joint injury, or it may be a wound over here or here. In both cases, use this is adhesive tape. This is the adhesive crepe bandage. You see the adhesive crepe means is having adhesive nature. It is available in surgicals. Okay, so is the joint strapping. You know the joint fracture in foot. The same order, joint strapping method. Okay, you press from the top and the bottom, and with the maximum pressure from the top and bottom, so that it will be aligned normally. Okay, this is the joint strapping method, and support from the top and to the bottom of the elbow. So both the area. Before that, you have to shave your area having hair. If the patient is having hairy, so there will be a painful method. It is the AC joint strapping method. So this is somewhat painful method. But even after doing this AC joint strapping method, there will be some deformity remaining even after 1 month of AC joint strapping method. It is normal. But there will be complete relief of pain after 1 month. So it is a joint strapping method, and after the it is a normal. After that, you have to use one shoulder immobilizer. Okay, you can use the shoulder immobilizer, elastic shoulder immobilizer. You can use one elastic shoulder immobilizer. So this is the elastic shoulder immobilizer to completely immobilize. This is the brace used for completely immobilizing with a severe injury of rotator cuff or a fracture. This is the elastic shoulder immobilizer. Okay, we can see a strap around the abdomen and a forearm strap and a upper elbow strap. So it is the elastic shoulder immobilizer with the joint strap. Okay. So this is the kinesio taping after removing the bandage, which is a professional cricket player. Okay. So both are different. This is different. This is different. Okay. So this is a joint strapping AC joint injury management. Okay, and we can see what I said earlier. If a patient came to OPD without history of trauma, but there will be definite lump over the AC joint, and there will be widening, and there will be osteoarthritic changes. Okay, like widening and sclerotic change. In such cases, you go for an MRI of the shoulder, especially mention AC joint pain and swelling. Okay. Okay, this was a case of TB. Okay, AC joint tuberculosis. It's a case of AC joint tuberculosis. So the patient came to OPD without history of trauma, definite pain, swelling, and X-ray suggestive of a widening with a degenerated margin. Okay, it may be AC joint pathology, AC joint osteoarthritis, or a tubercular arthritis. Okay. And is a fracture. It is not a fracture. It is a normal X-ray, but it is a fracture. It's a normal growth plate. Okay. In many doctors, they diagnose it as a fracture. It is not a fracture, but there is a fracture. This is a green stick fracture. Okay. It's a fracture. And the humerus shaft fracture. Okay. This is fracture is not in our topic actually. Shaft. This is the fracture of the surgical neck. Fracture and tuberosity. Actually, it is surgical, but the age of the patient is 84. This is our Cain labum, Karta Marmani labum with the shoulder immobilizer. We can manage without surgery if the patient is above the age of 80. Okay. And always remember, in case of a shoulder fracture, there will be a fracture of the greater tuberosity. It's very, very important. Fracture of the greater tuberosity because supraspinatus, infraspinatus, and teres minor attaches to the greater tuberosity. If the patient updated the shoulder, there will be avulsion fracture of the shoulder. So in case of shoulder fracture, first rule out the greater tuberosity fracture. So you have to use the shoulder immobilizer for 10 days. After that, you have to take another X-ray. If the fragment is displaced, go for surgery. If it is not displaced, go for 1 month immobilization. Okay, this is the greater tuberosity fracture again. Greater tuberosity fracture again. And another patient came to OPD, he is 48, and it is the avulsion fracture, a greater tuberosity with the surgical neck fracture. But there is no display, it is not displaced. And another case we can see, this is the fragment, this is displaced superior because the supraspinatus muscle came from this area and attaches to this area. If the patient abducted the shoulder like this, the fragment is upwardly migrated. So it will create a block here. This is the subacromial space. There will be a block, that is the subacromial impingement by the superiorly migrated greater tuberosity. So it is surgical. Okay, this is very, very important. And we can see the shoulder dislocation. This is the shoulder dislocation, and this is the before dislocation. Sorry, this is the before reduction. You can see there is a definite, and this is a normal dome of the shoulder before and after. Okay, and we can see the patient came to OPD with the shoulder dislocation. We can see a shallow dig area here, and after dislocation, we can see there is a definite normal dome of the shoulder. Okay. And if the patient with the typical presentation of the anterior shoulder dislocation, slightly abducted and externally rotated and held by the next hand. This is the typical presentation, slightly abducted from the body and slightly externally rotated and held by the another hand. So it is a typical presentation of a shoulder dislocation. You have to write X-ray shoulder if the patient is having a definite history of fall. If in case of a recurrent shoulder dislocation, you reduce it first. After that, you have to take an X-ray. Okay. In case of a shoulder dislocation, there will be anterior dislocation in 85 to 90% anterior dislocation, antero-inferior dislocation, 95%. 85 to 95% anterior dislocation. And in case of anterior dislocation, we can see the glenoid is over here and it is displaced downward and anteriorly. There will be humerus is located in the antero-inferior area. So this is the anterior dislocation of the shoulder. And in case of the posterior dislocation, humerus is displaced posteriorly. So there is the area we can assume a reverse bulb, inverted bulb appearance. Okay, we can clearly see on the glenoid here and posteriorly located inverted bulb inverted position. Okay, this is a posterior typical presentation of a posterior dislocation. So you note these X-rays. This is the anterior dislocation. We can see glenoid cavity here and antero-inferiorly displaced humerus. The back is area. That's why in the picture there will be a shallow area here. And in case of the posterior, there will be a reverse bulb appearance. Okay. So this is the posterior dislocation. This is the anterior. That's why in the posterior and anterior dislocation for a diagnosis, X-ray shoulder AP is enough for our practice. Okay. For the shoulder dislocation, there will be another methods, Couch's method, modified Couch's method. In our practice, Couch's method is using, and you have to immobilize 2 to 3 weeks. Okay, if there in case of a recurrent dislocation of the shoulder, immobilize the patient for 2 weeks. After that, you have to remove the bandage and start the range of motion movements. Okay, you have to use arm pouch if it is the recurrent dislocation of the shoulder, or if it is severe pain, tenderness, or it is an acute case of a shoulder injury, you use a shoulder immobilizer so that you can have a sudden relief of pain. Methods. Okay. In case of acute shoulder injury management, RICE protocol is very, very important. Rest, ice compression, and elevation. It is the RICE protocol. So you have to use ice pack. You take ice cubes and crush it using a towel. Never directly apply the ice. Use ice cubes in a towel and apply for 10 minutes. Apply the ice over the injured area 10 minutes. Not directly use a towel with a crushed ice pack. You can have ice pack 10 minutes. If it is an acute injury, 10 minutes in every 2 hours. Okay, 10 minutes in every 2 hours. So if you are going to bandage the patient, you apply the ice for 10 minutes. After that, you have to bandage the patient. Okay, if there is severe pain and swelling, Nagaradi and Jadamyadi together, you can use. Or Nagaradi alone can use. Otherwise, you can use Murivanna in the acute. Okay, and medicine of choice in my practice, Amrdarishtam, Purnamasam, and Nimbamrdasam is my choice in acute injury. And Laksha Gugulu we can use, Gandhadaila we can use, but in acute case, I will never use Gandhadaila. And Chandraprabha will be the option. Okay, and if there is a severe pain, Vetamaran in tender coconut oil, tender coconut juice for sudden relief of the pain. Okay, and in case of acute shoulder injury, if it is a fracture, immobilize for 1 month. If it is a soft tissue injury without a fracture, immobilize for 2 to 3 weeks. And if it is normal shoulder injury without a fracture, without a massive injury, you can have a shoulder arm pouch or arm sling or arm pouch you can use. It is the orthotics used in the simple injury, arm pouch or arm sling. If is a patient having severe pain swelling without fracture, but patient is having severe pain and swelling or severe pain, you can use elastic shoulder immobilizer. This is the apt for reducing the pain. Okay, because if you are using a sling, you can move your hand like this.